This program is brought to you by Emory University.
Good morning, everyone. Wissam Jaber here. Today, we have our interventional fellows present some cases that will illustrate the latest in complex coronary and pulmonary intervention. We've been blessed this year by excellent interventional fellows. I'll introduce them one by one. Nick Shekiladze is going to present first. Nick is finishing this year his interventional cardiology, and next year he's joining as a structural fellow. Then we have Bryan, who will be our CHIP fellow next year, a complex coronary interventional fellow. And Ahmad Al-Turk will present. Ahmad will be going on to be a structural fellow next year in Arizona. Co-moderating with me are Pratik Sandasera, who's our current CHIP fellow, with Leah Raj, our CHIP fellow too. Pratik will be joining us as faculty starting in May. And Leah is going to be faculty at Vanderbilt in Nashville as a complex coronary operator. We're very proud of all our class. Oh, sorry, Louis, I forgot about you. So Louis Verreault-Julien is our other CHIP fellow who's working with Stefan, mostly at St. Joe's, but also helping us here at AUH of Midtown. Louis is from Montreal, and he'll be going back to Montreal after he's done. So Nick, go ahead and present.
Good morning, everyone. Can you guys hear me okay?
Yes.
Good. So we decided to show you some cases today, and I'm going to start with a hybrid coronary vascularization case. We'll present a few slides on the data at the very end as well. I'm just going to go ahead and get started. I have no disclosures. So just to clarify at first, what we mean by hybrid revascularization is when a surgeon performs a single vessel bypass, Lima to LAD, with a minimally invasive approach, a small incision in the left chest, and also the harvest of the Lima happens endoscopically and robotically. So it happens on the beating heart, so there's no, it's basically an off-pump surgery. So what we know about Lima, we know that it's the best treatment for proximal LAD disease. It portends the mortality benefit. We also have data that shows the patency of the vein graft is very much comparable to PCI. In certain reports, sometimes you can see even up to 20% graft closure within 1 year. Also, we know that patients are interested in minimally invasive options if they can avoid sternotomy. Also, the rates of strokes are minimal with hybrid revascularization. They're very much comparable to PCI, partially because you don't have to cross-clamp aorta for go on pump. There's also no sternal infections, and there's an observational data that shows there's less bleeding, less transfusions, and shorter hospital stay. So I have a few video clips to show you about the procedure itself. First of all, let me kind of orient you here. So the way this surgery is performed, there are 3 trocars that are inserted into the left axillary, anterior and mid-axillary line. The inferior one is for the grasper, the center trocar is for the camera port, and the superior one is for the harmony forceps. So the procedure starts with direct visualization of the Lima, which is here in the center, and the surgeon basically dissects the endothoracic fascia medially and laterally, therefore skeletonizing the Lima and cutting off small veins and branches of the Lima, harvesting it for the anastomosis to the LAD. The next step is also robotically and endoscopically, you can separate the anterior pericardial fat and open the anterior pericardium, directly visualizing the beating heart and the target of the LAD. this picture, you can see LAD in the diagonal branches. The next step is to essentially decide on the location to where to perform the incision. There's a couple of ways to do it, and here you can see the needle going under direct visualization, essentially trying to guesstimate where the LAD is located and inserting the needle in that location. So that would be the destination for the incision. And sometimes surgeons, they just use an X-ray before the surgery, and they try to insert the camera report right where the LAD would be, and then they change the camera report trocar to where the final incision is going to be for the anastomosis. So the next step here is, you have a stabilizer for the heart, obviously, and you make an incision in the LAD. And in order to perform anastomosis without ischemia, they place a shunt, which is about 2 and 2.5 millimeter, that connects proximal and distal LAD vessel and allows myocardial perfusion while you're working on the anastomosis. In this video, you can see they use a running and uninterrupted suture to make anastomosis. And once they get to the point where it's almost sewn in all around the incision, then they take out the shunt at the very end and tie the anastomosis. So they check the flow after the connection is done. They check the patency of the conduit, confirm it. Essentially, those are the key steps of the procedure. The end result, you can see this very small parallel incision in the left chest. So let's talk about determining the sequence of when to perform a bypass first or a PCI. Ideally, the patients would like to have it done in the same setting. It's more convenient, same hospitalization. Also, what's nice about it, you can immediately confirm the patency of the lima to LAD anastomosis, and if there is any issues there, you may consider a surgical revision. But it's also okay to perform PCI first, and usually that happens in the ACS setting if treat a culprit vessel first, and we identify a good candidate for a hybrid revascularization, then the bypass might follow the PCI, and usually, a surgeon would have to operate on DAPT, where the surgery may be postponed for about a month or a couple of months. And the candidate for this procedure are anyone with a proximal LAD disease or distal left main into the LAD, patient with a good LAD target distally. And also the other coronary arteries should be intervenable by an interventional cardiologist. Mostly, we prefer it like if it's a focal lesion that can be well treated with stents rather than multiple stents. Some of the unfavorable factors are central obesity and the prior bypass because of the adhesions in the anterior chest wall, and if there's a diffuse LAD disease, it may be difficult to make the anastomosis. So I'm going to proceed with our case. 53-year-old female with a newly reduced EF of 25-30%, typical risk factors for cardiovascular coronary disease. Had a PET for ischemic workup and found to have reduced coronary flow, essentially balanced ischemia in this case. As you can't see any regional defect. This is the angiogram. We have a RCA CTO, proximal segment. And on the left coronary artery, there's a ostial 70% prox LAD disease. And if you kind of pay attention, there's a medium to large size OM2 that's filling late, which is also a CTO at the proximal segment. We had a heart team discussion and decided to proceed with the robotic lima to LAD and subsequently revascularize patient with patient's CTOs of both circumference and the right. So this is the conduit of Lima to LAD. You can see a good anastomosis, some competitive flow in the LAD. I won't go too much into details of how we perform this as CTO, but I'll just mention this was done with the antegrade approach. Usually we take a soft wire with a microcatheter to the proximal cap of the CTO and then exchange the wire to a higher ground tip load wire, which is a little bit sharper. And under direct visualization, we're able to drive it within the vessel architecture, or sometimes we are able to cross it true to true lumen. And here, we confirm the location of the wire by angiography. Basically, you can see the tip of the wire is in the true lumen on this left-hand video, and on the right, the wire was advanced further into the lumen. This is how it looks after stenting. We use IVUS 100% of the time for our CTOs. You can see the vessel is actually large. There's a little segment of remodeling, which is also expected sometimes to be seen. Next was the RCA CTO. This wasn't in the same hospitalization, but we brought the patient back in a few weeks. This is a little bit of a difficult antegrade approach, so it's an ambiguous cap. We decided to go primarily retrograde through septal collaterals. And we have on this right-hand video, you can see the several septals are connecting to the RPDA. And it's in a similar way, we use a soft kind of workhorse wire to navigate into the septal with a microcatheter and perform a tip injection to identify the septal that connects, and then exchange that for a hydrophilic jacketed soft wire. And this is in the middle screen, you see that what we call a surfing, identifying the connection to kind of allow the wire to cross into the right coronary circulation through the septals. I'm going to let it play for a while because you will finally eventually see how the wire crosses into the right about here. So we follow that with the microcatheter all the way to the distal cap of the CTO, the same wire and the microcatheter, and afterwards, sorry, next slide, we'll exchange that soft wire for a different type of wire, like a Mongo or a Gaia 3, also that has a higher penetrative capacity, and then we drill at the distal cap, which is usually softer than the proximal cap. And if you keep watching this left video, then eventually you'll see how the wire will change its direction, and eventually it'll go towards the guide and come out of the aorta. So this is the wire went into the aortic root. So I skipped a few steps, but we snare the wire, or sometimes we use the antegrade microcatheter to just directly wire into the microcatheter, and then we switch the case into the regular antegrade PCI. And I'll just show you here what the final result was of this RCA. The stents were placed from the distal to proximal RCA here, since it was a blown occlusion. So this is our final result for the patient. She was fully revascularized by the hybrid approach. We went to LAD, and circumflex and RCAs were revascularized with PCI. Interestingly, this is her EF. It was about 20–25%. And on the bottom, this is after 3 months, repeat echo, notable improvement. I can't say we see that every time, but this was one of those cases. So I have a couple of slides on the data for hybrid revascularization. There's a lot of observational data that has been published, and a lot of the papers came out from the Emory group as well. Dr. Halkos, who's leading our hybrid program. What they showed, so this is a propensity matched analysis comparing the hybrid revascularization to CABG, traditional CABG. They found that there's less bleeding, there's lower surgical site infections and shorter hospital stay, fewer in hospital complications. And there was comparable midterm survival. As far as a little higher level of evidence, so there's only one, the only randomized trial that's been done. It's called OMNITS or hybrid trial that compared hybrid revascularization to CABG. And this was originally not, it was originally a feasibility trial, and it wasn't powered to show a definite comparison to mortality, but they now published a 5-year outcome in 2018 that showed essentially no difference in mortality at 5 years, and also no difference in rates of myocardial infarction, coronary reintervention, stroke, or any other MACE endpoints. In the guidelines that came out in 2012, there's a 2A and 2B recommendation for hybrid revascularization. So it's reasonable in patients with those who have limitations to traditional CABG, have heavily calcified aorta, or poor target vessels for CABG, but those that are amenable to PCI. In somebody who lacks a suitable graft conduits, or in someone who has an unfavorable LAD artery for PCI, but would have a good target for lima. And also, it's maybe reasonable for patients with multivessel PCI and CABG, just to an attempt to improve the risk-benefit ratio for an individual patient from the procedure. So, in conclusion, wanted to just show you the case and what we know that the hybrid revascularization is safe, effective treatment. In order to build the program, the hybrid program at the institution, there should be a good collaboration from interventional cardiologists and cardiovascular surgeons. As far as data, so far we only have one randomized trial that has been published comparing the CABG to hybrid revascularization. There hasn't been any trial comparing PCI to hybrid revascularization, but we have one that's currently ongoing, and it's funded by NIH. It's currently enrolling, comparing PCI to hybrid revascularization. It will be 2,400 patients that they're targeting in this trial. This is the end of my presentation.
Bryan, thank you very much for this. So it's great how with excellent surgeons that we have here, Michael Halkos and Amalia, they're doing a great job with lima to LAD, combined with advanced skills in opening up CTOs, have really achieved a lot in terms of complete revascularization for patients and good long-term outcome. If there are any questions, if you guys can put them in the chat, we can try to tackle them later. But for the sake of time, I want to ask Bryan to move on to his left main case.
Thank you, everybody, for coming in and joining us today. I'm going to follow up, Nick, by showing a case of left main intervention that was done this year. So for our presentation, we have a 76-year-old male with a history of advanced COPD. He had recent COVID pneumonia with a pretty good degree of pulmonary fibrosis seen on his CT scan, and was at that point dependent on 5 liters HOMO2, CKD stage 3B, and systolic heart failure with an EF of 30% with pretty significant RV dysfunction and elevated right ventricular systolic pressures estimated on echo. He went to an outside hospital with pretty typical substernal chest pain radiating to the left arm and jaw, and was diagnosed with an NSTEMI. He had a diagnostic left heart cath that I'll show you in a moment at the outside hospital that showed severe left main disease that extended into the ostial LAD as well as the circumflex, along with heavy calcification burden in the vessels as well. He was transferred to Emory, where he was evaluated for a CABG, but due to his kind of high-risk comorbidities, he was felt to not be an operative candidate by CT surgery, and we were called to evaluate for revascularization options. So here's his outside diagnostic films. On the left, you really may not appreciate the left main stenosis as severe as it is. You can see it on the right, but on the left, you see the extension into the LAD kind of coming off at the top there. And then on the right, you see that the distal left main is pretty heavily calcified and narrowed with extension into the ostial circumflex as well. This is his right coronary artery, which you can see in the body has some moderate 50, maybe 60% stenosis, but not as severe as the left side. So I'll move forward now to the intervention that we performed. In patients with, high-risk proximal lesions, left main, ostial LAD, who have a lot of comorbidities or other risk factors, in particular, in this case, systolic heart failure, these with reduced ejection fraction, these are patients who we typically will think up front about the need for mechanical support with. And this is an example of us taking a picture of the aortoiliac and femoral system, kind of planning and anticipating for possible need for an impella. And we did ultimately go with an impella. I believe we went into the ventricle. His EDP was about 35 at that point. So we were kind of worried about doing this without any type of mechanical support. So the impella went in, and here's some pictures of us just getting started. I think one of the things you see on the right here is you appreciate the bends that wire's taking and how severe the calcium and stenosis is in the vessels. And here's an example of some of the other tools and techniques we had for these heavily calcified lesions that we think we need to modify the calcium or debulk it in a way before we can adequately get a stent in to deploy. This is an example of rotational atherectomy. So on the left, you see a burr there in the coronary that spins very, very fast. It's diamond coated with a cutting edge, and we can move that up and down the lesion and kind of debulk and take out some of that calcium. And the right is what the vessel looked like after we were done with the atherectomy. This is another example of some tools and techniques that are more kind of new, have come out in the last year or two. After the rotational atherectomy, we were still having trouble expanding balloons adequately to a place that we thought we were going to be ready to put a stent in because of the calcium. So this is a newer type of balloon called a shockwave balloon, which has come out or been approved in the last year or two. It uses lithotripsy, kind of basing some of its technology off of how kidney stones have been treated for the past couple decades, using ultrasound, high energy pulses to kind of fracture calcium from the arterial wall. And this is ultimately the stent going into the circumflex artery. There's a couple different techniques you can use for these bifurcation lesions. This one, because the circumflex came off at close to a 90-degree angle to the LAD, we chose to approach it with what's called a T-stenting technique. We'll see what that looks like at the end here. After that went in, we then turned our attention to getting the stents into the LAD. This is us lining up and deploying our stent on the LAD and making sure you extend that stent far enough back into the left main. One of the things here is the size difference between the LAD and the left main, and you need enough stent in both the left main and the LAD that the stent can be expanded after it's deployed to actually match the vessel size. So you typically have to go a little bit bigger, 1 to 2 millimeters bigger in the left main than the LAD itself. This is an example of stent optimization after the stents have gone in. On the left, you see a technique called a kissing balloon inflation to kind of optimize the stents in the LAD and the circumflex itself. And on the right is kind of the final balloon inflation. It's called a proximal optimization technique, where you see we pick a much larger balloon to make sure the stent is adequately expanded and opposed to the left main itself, and it's not kind of malopposed or floating in the lumen itself. This is some final pictures. I don't know if you guys remember what we started with that distal left main into the circ and LAD. And here's our final picture showing, much significantly improved flow and a result in kind of all three vessels or all areas that we worked on. And I figure I'd end briefly with this slide, which is a picture from an update from the 2021 revascularization guidelines for revascularization in stable ischemic heart disease. I kind of put a red box over on the left main area that we're kind of focusing on here today. The idea is if there's significant left main stenosis and not high anatomic complexity, PCI does actually carry a 2A recommendation, with CABG still being a class 1 at this point. There have been a couple clinical trials that have compared CABG to stenting for left main disease with kind of varying results and outcomes. There was a meta-analysis published a couple years ago looking at several of those trials and kind of pooling them, and it did come out to the conclusion that there was no significant benefit of one over the other, at least in the area of the composite endpoint death, MI, or stroke in the 3 to 5 year range. So that's what I got for an example of our left main intervention, and I'll turn it over to our next presenter after that.
Thanks, Brian. We've traditionally thought about left main lesion as a surgical disease, but it really doesn't have to be. In general, we'll look at patient's syntax score. If the patient has simple left main disease and not a lot of lesions elsewhere, then intervention with PCI would achieve similar long-term results than surgery compared to surgery. And obviously, it's also a good option for non-surgical candidates like this patient. There are new tools like the rotational atherectomy is an old tool, but new tool like the IVL lithotripsy that Brian talked about. And Pratik has looked at that in the left main in our experience. Pratik, do you want to comment on that? What did you find?
Yeah, so thanks, Dr. Jabber. So, this is one of the things we're seeing more and more. It's very heavily calcified, complex disease. And we looked at our own Emory experience. We had about 30 patients that underwent left main intervention with shockwave and 30 patients that underwent intervention with rotational atherectomy, which is been more, it's a little bit with technology. And we had, comparing those two groups, we had similar outcomes in terms of things that are important. So that means, sizing the stent and ultimately stent expansion were similar when patients were treated with lithotripsy versus atherectomy. And it really adds a new tool to our armamentarium for management of these complex patients with heavily calcified disease. And I think, we're looking forward to more data to kind of support its use in left main interventions.
And the big thing is that it appears to be much safer than rotational atherectomy, so something to consider, especially when you have patients with low ejection fraction. There was a question in the chat about when to use Impella. This case, Impella was used to treat patients. Leah, what do you think? When do we use Impella for these cases, complex coronary interventions?
Sure. I think the two main areas that we think about is people with bad comorbidities. So like Brian said, like severe like LV dysfunction, high EDP, but also anatomy. So for example, like if patients need rotational atherectomy, like in multiple territories, or long lesions that need atherectomy, or you'd expect like prolonged balloon inflations, things like that. That's certainly times you'd consider that. But like obviously they need appropriate peripheral anatomy to be able to do that.
And this is still studied now. We have a trial ongoing. We're contributing to this trial here at Emory. It's called Protect 4, where we're randomizing patients to Impella versus no Impella for complex coronary interventions with low ejection fraction. All right, Louis, go ahead.
All right. Thanks, Brian and Nick, for the excellent presentations. For those of you that I haven't met yet, my name is Louis Verreault-Julien, and I started as a CHIP fellow here in January. As you can see today, I will talk about complete revascularization in post-CABG patients. The objectives of the presentation are to discuss PCI after CABG, which did not receive the same attention as PCI versus CABG in multivessel disease in the past. We will also discuss the approach to a complex revascularization case, both before and after CABG. And we will also talk about the literature supporting the decisions that were made in this particular case. So the case that we're going to discuss is a 62-year-old male who presented in June last year with a non-STEMI. He had a past medical history of hypertension, dyslipidemia, diabetes on insulin, and obesity. The initial troponins were elevated around 14. The hemoglobin and creatinine were normal. and the BNP was elevated. And the EKG showed a left bundle branch block, and the TDE showed a moderately reduced LVEF at 35%. The patient was stable, so in that context, an early invasive strategy was chosen and patient was brought to the cath lab. On the left, you can appreciate that the left main is essentially normal. You can also see a moderate to severe lesion in OM1 and a CDO of the distal circumflex. On the right, you can see that there was a CDO of the mid-LED just past the first diagonal, and there was also a very tight lesion at the ostium of this diagonal. There is also an epicardial collateral from the ramus to the apical LED. In these two views, you can appreciate that there was severe calcifications in both the LED and the first diagonal. And in these two views, you can see that there is a moderate lesion in the ramus, which was not easily seen in previous use. In the RCA, there was a subtotal stenosis of the mid segment, which caused a TIMI2 flow. There was also an RPD lesion. And on the right, I wanted to highlight that there was a septal collateral from the PDA to the LED, but the LED did not light up very well because of the reduced flow in the RCA. So in summary, we had 3 vessel disease, almost 4 if you count the ramus as a different vessel, although physiology was not performed in both the OM and the ramus. Regarding revascularization in patients with diabetes and multivessel disease involving the LED, current guidelines would recommend CABG over PCI based on trials like Freedom and Barry 2D. But PCI is also recommended for PCI for patients who are deemed poor surgical candidate. And in this particular patient, the lack of visualization in the LED could have been regarded as a potential contraindication to CABG. As for completeness of revascularization, in the 2018 ESC guidelines, it was supported, but the more recent ACC-AHA guidelines did not make any recommendation about it. From observational studies, we know that incomplete revasc is associated with poor outcomes, but a causation relationship is difficult to make because these patients often have more complex CAD and more comorbidities. In the only good prospective data that we had, this comes from the Syntax clinical trial. Completeness of revasc did not seem to be that important for all comers. But when we look at the subgroup of patients with occluded vessels, like our patient, in that same Syntax trial, there seemed to be a benefit of complete revasc in both PCI and CABG, with reduced MACE rates with complete revasc. With that in mind, the patient underwent triple bypass surgery with LIMA to LED, SVG to RCA, and SVG to D1. The post-CABG TD showed an even more reduced LVEF of 20%, but the patient did well clinically and he was discharged about a week later with good medical treatment. After a non-eventful summer, however, the patient came back for unstable angina and he was again brought back to the cath lab. On the left, you see that the LIMA was atretic with a TIMI1 flow. And on the right, you can see that the SVG to RCA had a severe ostial stenosis. The RCA and the circ and the ramus were essentially unchanged. What had progressed, however, was that the severe ostial D1 stenosis was now completely occlusive, and the diagonal was filling from collaterals. Unfortunately, on this exam that was done on a peripheral hospital, the SVG was not selectively injected, but the fact that we had retrograde filling was strongly suggestive that the graft was also non-functional to the first diagonal. In that context, it was decided to do a PCI of the mid-RCA and RPDA, which was probably the right decision because it's associated with lower adverse events than treating the vein graft. And on the right, you can see that now that the flow had been restored in the RCA, there were nice collaterals filling the LED. So it's kind of the first time that we could see the LED well. So even though it was probably the right thing to do a PCI of the low-hanging fruits that were the mid-RCA and PDA, the patient remained with 3 occluded arteries, the LED, first diagonal and circumflex, and 2 moderate to severe stenosis with no physiology performed in the ramus and OM1. And the patient had no functional graft anymore. So you can imagine that following this procedure, the patient did not do very well. He was referred in December to one of our colleagues for worsening angina. Our colleague decided to do a cardiac MRI for viability, which was present in all coronary territories, and fortunately the LVEF went up to 36%. We decided with our colleague and the patient to bring the patient back to the cath lab to assess physiology of all non-CTO lesions and to do complete revascularization in a 2-step procedure, everything during the first procedure except the LED and the1, which would be left for a later procedure. And this idea of going ahead with PCI was also indirectly supported by the guidelines, which state that in patients with previous CABG, a redo can be done when an IMA can be used as a conduit to LED. One could say that a REMA could still be used, but there was no argument suggesting that it would do better than the non-functional LEMA already grafted. We started by injecting the RCA, and surprisingly, we found a severe stenosis at the distal edge of the previously placed stent in a mid-RCA. The previous PCI was not done on, with IVUS, so we did IVUS, and it showed a grossly underexpanded stent with some geographical miss. So we treated it by expanding the stent better and implanting a new DES 4.5 by 16 post-dilated to 5.0. So I think this highlights very well the importance of intravascular imaging in PCI. We then switched to the left system, which stayed pretty much stable since the last cath in September. We did an RFR of both the ramus and the OM, and both were strongly positive. So therefore, our strategy was PCI of a ramus, OM, and distal circ. We started by the ramus, again, always IVUS guided. We implanted a 2.75 by 28 DES with good result both on IVUS and angiography. IVUS in that case not only allowed us to size the stent better, but also to make sure that there was a healthy landing zone in the proximal portion of the ramus, and it let us avoid the ostium of the ramus. We then advanced a wire in the OM, which was easy, and then we proceeded with integrated wiring of the distal circ with the Mongo wire, which is a polymer jacketed wire that is very slippery. We advanced these wires in distal arteries, but then switched for safer wires for the rest of the procedure. On the left, you can see that we predilated the distal circ with a tube balloon, and on the right, this is after predilation. Again, IVUS allowed us not only to size stents, but to make sure that we had healthy landing zone distal to the bifurcation. So we could avoid to do a bifurcation stenting technique for this circumflex territory. So we put a 2.5 by 38 in the OM post-dilated to 2.75 and a 2.25 by 20 in the circ. As Nick said earlier, we often see in CTO PCI some sort of remodeling in the distal vessels, which was confirmed here with IVUS. So in summary, for that first step of our complete revascularization PCI, we did the mid-RCA ramus, OM1, and CTO of distal circ. So the patient was brought back to the cath lab about a week later, and the case was done in the context of the CTO Plus conference with the idea of doing the LED and first diagonal. Dual injection here was necessary for 2 reasons. The first one was that the target vessel in the LED, the distal vessel, was seen only with contralateral injections. And the second reason is that although our first strategy was integrated wiring, we had the idea of switching rather quickly to a retrograde approach, which would have been done through the septal collaterals from the right. The first diagonal was wired with a radar wire, which is also a polymer jacketed wire. After exchanging for a safe wire, we crossed the proximal cap of the LED CTO with the Judo 3, which is stiffer than the workhorse wire, but still considered as a relatively soft wire in the CTO world, we reached the distal cap, and then we re-entered the true lumen with the Gaia X3, which starts to be a bit stiff of a wire. We predilated both the first diagonal and the LED with non-compliant balloon at high pressure, but as you can see on the left, the balloons would not expand nicely because of the severe calcifications that were obvious both on angiogram and IVUS. So we proceeded with calcium modification techniques. We talked a bit about it earlier in Bryan's case, but we did first rotational atherectomy in the LED with a 1.5 burr, and then we proceeded with intravascular lithotripsy in both the first diagonal and the LED. And on the right, you can see that the stent that we put in the mid to distal LED, where the calcifications were the worst, is nicely expanded. I don't have all the images, but then we proceeded to the LED D1 bifurcation in a double kissing tap or DKT fashion. You can see on the left that we used a balloon in the LED to make sure that we position the stent in the first diagonal right at the ostium. And then you can see that following calcium modification technique, the stent in the first diagonal is expanding nicely. We then did the final kissing inflation and the proximal optimization technique to make the stent round and well opposed in the proximal segment. And this was our final result in the LED. Again, you can see some sort of remodeling in the distal vessel. We made sure it was indeed remodeling and not atherosclerosis by IVUS. So in summary, for the second PCI, we did CTO of first diagonal, CTO PCI of the LED, and it involved a bifurcation lesion as well. The patient did well following the PCI. He was discharged the very next day. We have yet to see him in clinic, but it should be in the next few weeks. I think the take-home message for this case is that patient selection for both approaches is very important. Of course, disease complexity and patient comorbidities are important. In this case, patient had a three-vessel disease involving the LED. He was diabetic, low LVEF. So we know that when surgery achieves good result, this patient is clearly a surgical candidate. However, the likelihood of success of the revascularization strategy must be also considered. And this is true for both surgery and PCI. For the surgical approach, you must make sure that the graft will remain open, and the fact that we could not see the distal LED before grafting a lima on it was maybe not a good sign that the lima would stay open. And as I said, it's true also for PCI. We have to use all the tools that we have in our box, namely intravascular imaging and physiology. In that case, IVUS was not done for the first PCI of the right, and you can see that the result a few months later was not excellent. As for completeness of revascularization, I think for when you have CTO lesions, I think both with PCI and cabbage, it's key to achieve good mid and long-term results. And although in many cases, I should say, cabbage will achieve it, in some situations like this one, PCI can do better.
Very nice case, Louis. Really illustrates what we can do in the cath lab. But I just want to make one point that you kind of alluded to. One of the biggest predictors of what patients get sent to bypass when they have multivessel disease is having a CTO. What people don't realize is that CTO bypass in the circumflex and RCA, the patency of SVGs there is really low. In some studies, as low as 20 or 25% in 1 year. So stenting these, if possible, usually achieves a better long-term outcome. Stenting CTOs, the patency is more than 90% in studies. So it achieves better results than having an SVG to this artery. Hence, if you have a good hybrid approach, that would probably be the best of both worlds. All right, Ahmad, are you ready?
Yes. Always. Good morning, everyone. Thank you for the opportunity to share and present our work, and thank you, Dr. Jaber, for the kind introduction. I'm Ahmad, Al-Turk. I'll be presenting a case of acute pulmonary embolism. I have no relevant disclosures to the topic discussed here today. This is a case of a 30-year-old man who presented with 2 episodes of syncope, along with new onset dyspnea and recent travel history. He has past medical history of obstructive sleep apnea, obesity, type 2 diabetes, and no history of COVID-19 infection. His review of systems was otherwise unremarkable, and he had no upper respiratory symptoms. On examination, he was tachycardic with an initial soft blood pressure that improved after IV fluid hydration. He was requiring 2 liters of nasal cannula to keep his sats around 95%. He was in mild acute distress and had some labored breathing. His initial labs, troponin of 0.26, that peaked to 1.86. His BNP was normal, hemoglobin was 12.9. His estimated GFR was 92. His ALT, AST were 3 to 4 times the upper limit of normal, and the initial lactic acid was not obtained. This is his initial EKG. As you can see here, there's sinus tachycardia, right axis deviation with the typical S1, Q3, T3 that we all hear about. This was followed by obtaining computed tomography, time to filling in the pulmonary arteries to evaluate for pulmonary embolism. And as you can see here, there is a bilateral pulmonary embolism involving the left main, along with the multiple lobes on the right and left side. The bottom right of the screen, you can see an enlarged RV with an RV to RV ratio that is high. This is suggestive of RV strain. This was followed by a 2D echo, and as you can see here, there is a significantly enlarged RV with decreased RV free wall, again suggestive of RV dysfunction. On the other side, you can see an underfilled LLV with the septum bowing from the right to the left side. All of this together, the evaluating team has asked for pulmonary embolus response team evaluation. And when we saw this patient, this was our summary. He had extensive pulmonary embolism with persistent symptoms and oxygen requirement. He had evidence of RV dysfunction along with elevated pulmonary arterial pressures on echo. He had favorable anatomical locations with no contraindications, and these are really all the things we look at when evaluating a patient with an acute pulmonary embolism. As a result of that, pulmonary catheter-based pulmonary embolectomy or thrombectomy was recommended. When we talk to our patients, we always go extensively through the risks and benefits of the procedure. Among the benefits, we can definitely take the clot out. This may result in symptom improvement, decrease in oxygen requirement, decrease in pulmonary artery pressures, improvement in the RV dysfunction. This can all lead to faster hospital discharge, and all of this may carry potentially beneficial long-term outcomes. When we talk about the risks, the most quoted risks include bleeding at the access site or damage to the pulmonary vasculature. There is always risks associated with moderate sedation. We can always have suboptimal results at the end, sometimes procedural failure, or even worse than what we started. There's always risk for peripheral vascular injury. But putting all of this together, the benefits in this situation were obviously higher than the risks. The patient was in favor of this procedure. However, he wanted to hear more about how is the procedure done. So typically we start with venous access. We obtain femoral angiography, femoral vein angiography, particularly to look if there's any clot in our way, because we can potentially push this clot up when we do our procedure. This is usually followed by an IVC, selective angiography, for the same exact reason. After that, we move our equipment up and we start by obtaining a right heart catheterization. Then we do selective angiography on the left and the right side. And sometimes you can see a relatively normal pulmonary angiogram tree, as you can see here. There is no filling defect proximally. There's some filling defect very distally, and there's definitely nothing to do on the left side. But sometimes you can have a large thrombus burden, as you can see here, a filling defect in the middle lobe and the lower lobe of this right side. And once we confirm favorable anatomy and continued presence of the clot, we take our equipment out. We usually upsize our After wiring the pulmonary artery with a soft wire, we exchange to a stiffer wire. We upgrade our venous access. Usually we use a dry seed sheath. And through this, we place an inari thrombectomy catheter, as you can see in this image here. And this catheter usually sits in the main right or left pulmonary artery. And after successful thrombectomy, and as you can see here, we can have nice results, resolution of the filling defects, and restoration of flow to the whole pulmonary tree. This is actually another case from a patient we did earlier this year. Now we go back to our patient. This is his initial image on the left side, extensive clot in the upper and lower lobes on the left side, segmental and subsegmental. And after performing vacuum-assisted thrombectomy, this is the final results on the left side. Significant improvement in the flow, and a significant amount of clot was extirpated. Moving to the right side, this is just selective angiography of the right lower pulmonary tree, and you can see barely any filling. This is all extensive clots. And this is the final picture on the right side. Significant improvement, restoration of flow. There's some residual defect, more distally, but this is definitely too small to do anything about catheter-based. So this is just a still image showing what we did pre and post on the left and right side. If you look to the top of the screen, there's significant clot burden that was removed. We used in this case the inari thrombectomy catheters. We used a T24 for the more proximal and large vessel, and T16 for the distal vessels. And top left of the screen, very important. This is a new addition to the thrombectomy system, is a filter. This is actually a blood saver. We now can do this procedure with very minimal blood loss, thanks to this filter. This is the right heart cath numbers before and after. We started with PA pressures of 86/43 with a mean of 60, and the result 53/29 with a mean of 34. Again, improvement from severe to moderate. Now this, I'm just gonna stop here for a second. An RV systolic pressure and PA pressure in the 80s, this may suggest some chronicity or some other concomitant cause for elevated PA pressures in this patient per se. But, and this is again the patient population that would benefit from things if we can, decrease their PA pressures acutely. And one important thing, you don't see a wedge pressure there, and that's particularly on purpose, because you don't want to be pushing your catheters and equipment and possibly pushing the clots towards wedge for this position, and you can definitely hurt the patient doing that. We had a cardiac output of 5.65 at the end of the procedure. Day one, post-intervention, patient was weaned off oxygen. He reported improvement in his breathing. He was transitioned to oral anticoagulation. He was downgraded from the CCU to the floor. An ultrasound showed an acute DVT in the left posterior tibial vein. He was discharged on day 2 with a plan to follow up in clinic for further testing if indicated. He was seen 3 to 4 weeks later, and a repeat 2D echocardiogram was obtained. As you can see, almost resolution in the RV dysfunction size as well, and a happy LV. So what do we learn here? We learn that these patients with acute pulmonary embolism in the current day and time, we have a lot to offer, and we can definitely help restore the pulmonary artery flow and pressure. And together, hopefully, we can make the RV great again. Thank you.
Thanks a lot, Ahmad. Very nice demonstration of new techniques. And this is a field that keeps evolving. Almost all patients that we perform in the cath lab or we even see on the floor are entered in registry or trials, multiple trials going on in this field right now. This is different from treatment of chronic pulmonary hypertension. Bryan had a case, but I think we're going to skip that, Bryan, for the sake of time. We could do another grand round on the intervention on chronic thromboembolic pulmonary hypertension, which is totally different from acute pulmonary intervention. We'll stop here. If there are any questions, we'll entertain them at this time. All right, it's 8:25 and no further questions. We're probably going to conclude. Any final comments, guys, that you'd like to make?
Thank you so much, fellows. That was fantastic. I have a quick question. Whenever anybody is asked to kind of evaluate in the CHIP program, do you guys get together and discuss the case to determine whether, what goes into deciding whether somebody is a candidate or not for CHIP?
I'll let Pratik and Leah answer that.
Hey, Dr. Miller, that's a great question, and we have some very, very experienced operators with Dr. Rinfrey, Dr. Jabber, Dr. Nicholson. So we'll usually, we have a meeting every week where we'll discuss cases, complex cases. So that's where we'll discuss amongst our team about the revascularization options for patients, and other interventionalists on our team, if they have any questions of potential patients, they'll ask us to look at. So we will discuss them as a team, usually weekly, to evaluate for complex interventional options for these patients. And so I think that's definitely, with the experience we have, it's a great way to kind of figure out the best way to treat these complex patients. And then we'll usually, if we think they're a candidate for hybrid revascularization, then we'll obviously discuss with our surgeons, Dr. Halkos. And so that's usually our typical process. Leah, you have anything?
Yeah, no, and I think for me and Pratik and Louis, it's great to kind of hear Dr. Jabber and Dr. Nicholson, Dr. Renfrew kind of discuss these patients among themselves, because we get an idea of what we should be looking for in the future when we're out doing this ourselves.
Great.
There was a question by Dr. Taylor about the NIH trial for PCI versus hybrid revascularization, which was a non-inferiority of hybrid versus PCI. But to my knowledge, this was stopped. We're part of this trial, unless Nick, you know about something different. But this was a trial that was conceived a few years ago, and then the recruitment was so slow that eventually it was stopped. I don't think there's any trial going on now.
Sorry.
What I saw basically is the same thing. Officially, I don't think it's stopped, because on the clinical trials website, it's still ongoing. But you're right, the enrollment is very slow now.
It's still on because they're following up on patients that were already done, but the trial was stopped. And unfortunately, we're not going to have any good data. It would have been great to have such data, which is needed, but unfortunately, it's not happening. And I'm not aware of anything happening anytime soon.
Taking your pills yet?
Wissam, Stan Sherman. Just on the chronic I know you didn't have time for the chronic thromboembolic pulmonary hypertension patient, but I take it the reason you're going to bring it up is because you're doing catheter technique. How do you decide catheter technique versus surgical technique if you're in the chronic patients?
Good questions, Stan. This is a topic that I'll probably give a grand round sometime in the next few months about that. All the patients that are chosen as part of a team that includes a cardiothoracic surgeon. Here, Mani Danishmand is doing these, and our pulmonary hypertension specialist from Pulmonary. So we have a meeting every other Wednesday where we run these cases and decide who's surgical candidate, who's not. Surgery is the number one choice. And again, this is for chronic, not acute. Surgery is the treatment, but if patients have very distal disease, residual disease, or not surgical candidate, then these go to the cath lab, and we have really reasonable results. And I'll be happy to show that in the next grand round. All right, it's 8:30, and I want to thank everybody for their time, and thank you, our fellows, for the great presentations. Have a good day.
The preceding program is copyrighted by Emory University.